In the history of mankind, we've seen a lot of dictators rule this land. We've also seen a lot of inhumane measures that they have imposed. In this session, I'd like to talk to you about one such dictator who and his inhumane methods. And this dictator is Emperor Zhou. Emperor Zhou was the last king of the Shang dynasty, and he was known for all his cruel methods of torturing his people. One method of his that became very famous is the procedure of foot binding. So he put up a penalty to all the young women in China, saying everyone has to undergo this procedure of foot binding, where the leg was broken down, the foot was broken down, and then it was tied tightly with a cloth. After this, the deformed foot that is formed was called as the lotus foot. And Zhou believed that this lotus foot was a sign or was an identity of true feminine beauty. This culture of foot binding continued even after the Shang dynasty collapsed because people in China believed that this was a status symbol. So this foot binding continued all the way up till the 20th century. Now let's understand why Emperor Zhou put this imposition of foot binding to all the women in China. The reason for that is he had a concubine or a wife by the name of Daji, and he loved Daji very fondly, and he believed that she was a sign of true feminine beauty. Now Daji had a foot deformity, and this foot deformity at that time was called as the lotus foot. And because Emperor Zhou believed that she was a sign of true feminine beauty, he wanted all the women in China to have the foot exactly like that of Daji, and hence he introduced a technique that is foot binding. So in this session, we'll be talking about the same condition that Daji had, which Emperor Zhou called as the lotus foot, but now we know this deformity as congenital talipes equinovarus. So let's understand what is congenital talipes equinovarus. So let's break the word down. It's called as congenital because it is seen at birth. Now, why is it called as talipes? So the reason it's called tali is because talus means ankle. So this deformity involves the ankle, and pes stands for foot. So it involves the ankle and the foot region, and the reason it is called as equinus is because the foot is in an equinus position. That is, it looks like tiptoeing movement. In horses, whenever they run, you notice that they don't keep their foot down. They have their foot in a tiptoe movement. So that it looks like a horse. So in equinus is horse-like. So equinus is like a horse. That is a deformity that is seen. And there is a varus movement of the foot. So if you see a clubfoot or a Ctev, you will see that there is an inward or a medial varus movement. That is why we call it as congenital talipes equinovarus. Congenital because it is seen at birth, tali because it involves the ankle, pes because it involves the foot, equinus because like a horse which walks in a tiptoe movement, even these patients have a tiptoeing. And varus because that foot is turned inwards. Now Ctev is also called as clubfoot because if you observe the golf clubs that are there, the shape of that golf club and shape of the foot is very similar. That is why it is called as a clubfoot. So that we've understood the naming, how it is called as clubfoot and why it is called as Ctev. Now let's understand the historical aspect. We know that Ctev has been there from a very long time. I've already given you an example of an emperor and his concubine having Ctev, which he called as a lotus foot. This can be traced down even to the Egyptian civilization, where a king by the name of Tut had this deformity. So if you see all the literature in Egyptians, you will notice that they describe a deformity that King Tut suffered from, and that deformity is very similar to the Ctev condition that we see now. Also, if you see paintings of pre-conquest Mexicans, you will notice that they've drawn something that looks like a clubfoot. So you can see depictions of clubfoot even in pre-conquest Mexican eras. Even Yajurveda talks about Ctev. He also talks about massage using to correct it. Also, Hippocrates talks about this. So he's the first to describe clubfoot. And even Scarpa described the pathologic anatomy, what causes CTEV. So there is a lot of histological traces of CTEV that we can find. Now coming to the definition, we know that it is a congenital dysplasia of the musculoskeletal tissues distal to the knee joint. That is, it is affecting the foot and the ankle. So it is a congenital dysplasia of the musculoskeletal tissues, and it specifically occurs only at the foot and the ankle. That is distal to the knee joint. It does not occur more proximally. So if you have an idiopathic type of clubfoot where the only deformity is seen below the knee, that is your ankle and your foot region. So what does it involve? It involves the musculotendinous structures, the ligamentous structures, the osteoarticular surface, and even the neurovascular structures. So every structure is affected in CTV. The nerves, the vessels, the joint, the ligaments, and the muscles. Also, it is a developmental deformity. It is congenital and a developmental deformity. Now, before going into CTV, we have to understand the anatomy of the foot so that we can better understand CTV. So we need to understand the bones, the ligaments, the muscles, and also what are the structures around it. So first, let's understand what joints are seen. So here we have the distal tibia and the talus and also the distal femur. So they form an articulation, and that articulation is the ankle joint, where the distal tibia, distal fibula, and the talus articulates. Also, below the talus, there is an articulation between the talus and the calcaneum that is called as a talocalcanean or a subtalar joint. So, because it is below the talus, it is called as a subtalar joint. Now, there are other articulations like between the calcaneum and the cuboid, that is a calcaneo-cuboid articulation. Between the talus and the navicular bone, that is a talonavicular articulation. And between the naviculi and the cuneiform bones, that forms a naviculo-cuneiform articulation. And the cuneiform also articulates with the metatarsals, forming a cuneiform metatarsal articulation. And then there are distal joints as well. So based on these joints, we can divide the foot into three sections: the forefoot, the midfoot, and the hindfoot. So we have the hindfoot, we have the midfoot, and we have the forefoot. Now we have to understand which joints belong to which area. So the hindfoot is mainly this section and this section. So we have the subtalar joint, and we have the calcaneo-cuboid. So these two joints, that is a subtalar joint and calcaneo-cuboid joint, form the hindfoot. The midfoot is formed between the talonavicular joint and also the naviculo-cuneiform joint. So we have the talonavicular joint and naviculo-cuneiform joint. So these two form the midfoot. Now the forefoot is formed by your naviculi, so your cuneiform and the metatarsals. So it is formed between the cuneiform and the metatarsals and also the distal joints. So this articulation between the cuneiform and the metatarsals and all the other distal joints form the forefoot. So we've understood what is a forefoot, what is a midfoot, and what is a hindfoot. Now let's understand the medial structures. So because in CTV, medial structures and posterior structures are affected. So we need to know what medial structures are there in the foot. So first let's understand the medial ligaments. The first ligament is this deltoid ligament that is forming an articulation from the medial malleolus down to the foot. So this is a very important ligament as it is a medial collateral ligament. It gives stability to the medial structure. So deltoid ligament. Also there is presence of a spring ligament that is between the talus and the naviculi, even that is giving a medial support. So the second one is a spring ligament. And we also have a plantar ligament. So plantar ligaments are formed between metatarsal bases and also the calcaneal tuberosity. So it gives the longitudinal arch of the foot. So you have the arch of your foot. Your foot is not flat. There is an arch to your foot, and this arch is given by the plantar fascia or the plantar ligaments. So these three are the main ligaments that are seen in the medial side. There are two more ligaments which are important. One is the interosseous ligament. And second, you see a thickening in the capsule, and these thickenings are noticed in the talonavicular and the navicular-cuneiform area. So you have capsular thickenings at the talonavicular and navicular-cuneiform. These are called as capsular ligaments. So we have five very important medial structures. Deltoid ligament is the most important. It is a medial collateral ligament. Spring ligament is also seen joining the talus to the naviculi. Plantar ligaments are there. We have interosseous ligament and we have capsular thickened ligaments. Now we have to understand the muscles. So these muscles that form tendon and floor right in the medial structure is very important to understand which structure is present where. So we take these ligaments in relationship to this process, that is the medial malleoli. So we look at the structures in relation to the medial malleoli. The structure immediately posterior to the medial malleoli is your tibialis. So if this is our medial malleoli, as you can see in the diagram, the first structure that is passing by it is the tibialis. The second structure is the flexor digitorum longus. So the second structure passing by and going to all the digits is the flexor digitorum longus. Now after that, you have presence of tibialis posterior vessels and artery and nerve. So these are seen, and after that you have another ligament that comes in, that is your flexor hallucis longus. So you can see here the flexor hallucis longus. So very easy way of remembering this is behind the medial malleolus we have the presence of Tom, Dick and Harry. So T here stands for tibialis posterior, D stands for flexor digitorum longus, and H stands for flexor hallucis longus. So this is anterior most and H is posterior most. So very important to remember that these three structures are seen, and more importantly, in a case of a clubfoot or CTEV, it is a tibialis posterior. So this is very important. So if tibialis posterior is contracted or damaged, your CTEV is more aggravated. So the most important muscle is the tibialis posterior. Now let's understand the different deformities that are seen in the foot. So all foot deformities can be brought down to a basic 7 deformities. That is, first is an equinus deformity. In an equinus deformity, the foot is present in plantar flexion. So dorsiflexion is not there. It is placed in a plantar flexion movement, and this is called as equinus. The reason it is called as equinus is because equinus means horse-like. So if you see a horse running, you can see in this image, whenever a horse runs, it runs with a tiptoe. So it is running with a tiptoe. It is not keeping its complete foot down. It runs with a tiptoe. That is, the foot is in forced plantar flexion. So similarly, even in an equinus deformity, a person will have a horse-like foot. So that is why it is called as equinus. Now the opposite of equinus is calcaneus. When you have a dorsiflex foot, that foot is called as calcaneus because most of the pressure when you're walking is falling on the calcaneum. That's why it's called as a calcaneus deformity. Next is varus and valgus. Now this is based on whether there is an inversion and a medial adduction force. So if there is adduction, medialward turn and inversion, that is called as varus. If there is eversion, abduction and a lateral movement, that is called as valgus. So a varus force is when inversion, medial rotation and adduction is there. A valgus force is when eversion, abduction and lateral force is there. Now coming to other deformities, A cavus is when the foot is like a cave. So I told you that in a normal foot we have certain amount of curve, and this curve is given by the plantar fascia. Now if that curve is more exaggerated, that looks like a cave. So that is called as cavus. The opposite of that is planus. Planus meaning a flat foot. So there is no curvature seen. It is a flat foot. Exaggerated is called cavus. Straight foot is called planus. Now, if the medial longitudinal arc is spoiled, that will lead to splaying. So this is a damage of the longitudinal arch. This is a damage of the medial arch or the transverse arch. Now coming to the etiology, we have to understand what is the cause of CTV. So it can be idiopathic or it can be syndromic. So idiopathic is when there is only one musculoskeletal deformity. So the CTV is occurring below the knee level and there is no other deformity seen. So when there is a single musculoskeletal deformity in an otherwise normal infant. So CTV is the only problem. There are no other causes. That is an idiopathic and this is most commonly seen. Another one is syndromic. Syndromic is when there is another cause which is leading to CTV. That cause can be arthrogryposis multiplex congenita, a Down syndrome, chromosomal deletion syndromes, and constriction band syndrome. So on all these conditions, it is a syndromic type of CTV where a patient presents with more than a CTV problem. There are other deformities also present. Now coming to the theories, so there are a lot of theories as to what causes clubfoot or what causes CTEV. Let's run down these theories. So first were the theories for idiopathic clubfoot. Mainly there was a mechanical theory where they said that because of a raised intrauterine pressure that forces the foot against the wall of the uterus. So if you see this USG, you can see that the foot here, this is the foot, is being pressed up. This is the foot. So this is getting pressed up against the intrauterine wall. There is a mechanical force here and that mechanical force can lead to CTV. So that is a mechanical theory that there is a raised intrauterine pressure because of the push against the uterine wall. Second is the ischemic theory where there is ischemia of the calf muscles during intrauterine life due to an unknown cause. And this cause is related to contractures. So these causes are results of contractures. Now coming to third theory, that is genetic theory. They say that because of any genetic disturbance, they can have CTV. So these are three theories that are commonly followed in idiopathic clubfoot. Mechanical theory, ischemic theory and genetic theory. Now coming to syndromic clubfoot. In syndromic clubfoot, they had two theories. One is it could be because of a paralytic disorder. So it is seen that in polio and spina bifida, there is a secondary clubfoot that is developing. So this occurs because there is a stronger inverters and plantar flexors and there are weaker everters and dorsiflexors. So the power of the inverters and plantar flexors in conditions like polio and spina bifida is high and everters and dorsiflexors are low, because of which there is a forced inversion and plantar flexion leading to a clubfoot deformity. So that was a theory commonly seen also in myelodysplasias and Friedreich's ataxia. So in all these conditions, it could be a paralytic disorder. Now we know that in arthrogryposis multiplexa congenita, you also see this. So in AMC, what is the cause for CTV? That is because in AMC, there is a defective development of muscle. These muscles go into fibrosis and this fibrotic muscles can cause foot deformities and also they cause deformities in all the other joints. So if you're suspecting a case of AMC, then you should look for multiple joint involvement and multiple contractures. Now let's understand the bony anatomy of how the bones are in CTV. So the talus is the most common bone that is affected. So this has a small body and a short neck. And talus is the fulcrum of the deformity. All the deformities that occur in CTV starts from the talus. So talus first has a small body and a short neck. Even the calcaneum is small and it is medially deviated. Also the other muscles or other bones like cuboid, metatarsals and naviculi are medially deviated. So this is the bony anatomy of CTV where talus has a small body and a shorter neck. Also the calcaneum is medially deviated and small. Even the other bones like your cuboid and naviculi are small and they are also medially deviated. Now let's understand which joints are involved and what deformities are caused. So at the ankle joint, we see equinus. At the subtalar joint, we see inversion. At the mid-tarsal joint, you see cavus and adduction. So we know that a cave deformity is commonly seen. Here cave stands for cavus, adduction, inversion and equinus. So these deformities are seen differently. Cavus and adduction is seen in the mid-tarsal joint. Inversion is seen at the subtalar joint. Equinus is seen at the ankle joint. So this is how the deformities are present in different joints. Now coming to the muscles. So muscles, posterior structures muscles which are tendo-Achilles. So commonly we have the tendo-Achilles muscle. This tendo-Achilles muscle is contracted. So normally the tendo-Achilles muscle keeps the foot in neutral. Now because the tendo-Achilles is contracted, so there is a pull of tendo-Achilles muscle which is contracted, that leads to an equinus deformity. So this equinus deformity is coming out of a tendo-Achilles injury. So when you have to repair an equinus, we have to do a tendo-Achilles release. So I hope you understand, when we talk about surgery later, we'll talk about how equinus is corrected by correcting the tendo-Achilles. That is because the contracted tendo-Achilles is the one that is causing the major equinus or the tiptoeing that we see. So the treatment also should be repair of the tendo-Achilles. Now medially we have muscles like tibialis posterior, flexor genitum longus and flexor hallucis longus. I talked about Tom, Dick and Harry being your medial structure. So these medial structures are contracted as well, and because of that contracture you have a medial deviation. Also that is the reason you have an adduction and a varus force. Now coming to capsules and other ligaments, you have posteriorly three structures, that is posterior capsule of the ankle, posterior capsule of the subtalar joint and the posterior talofibular and calcaneofibular ligaments. Medially you have three ligaments, that is talonavicular, spring ligament and deltoid ligament. Plantar you have plantar fascia and plantar ligaments, and others you see intraosseous ligaments which is between the talus and calcaneum. So all these muscles which are present in the posterior medial structure. So you can see here posterior and medial structures. So most of them are posterior medial structures are contracted. So in CTEV, the pathological side is the posterior medial side. I hope that is clear. See, because all these capsules and ligaments are affected, so the pathological side is this posterior medial side, which is leading to a shorter medial column and a larger lateral column that is giving rise to this deformity. So let's understand the deformities. I've already talked about that. Cave is the short form to remember it. C stands for cavus, where there is an exaggerated longitudinal arch. There is adduction, that is there is a medial force. Also there is inversion. This inversion is because of a medial directed and a varus directed force. Also there is equinus. This equinus is because of contracture of the tendo-Achilles. So you have a cave deformity. It is also important to know which deformities are present in the forefoot, which deformities are present in the midfoot, and which deformities are present in the hindfoot. So your forefoot deformities are your adduction. So you can see here forefoot adduction is there. And in the midfoot, you can see cavus. This cavus that you see here is a midfoot deformity. And the hindfoot deformity is varus and equinus. Very important to remember this, which are your forefoot, midfoot and hindfoot deformities. So in cave, C is a midfoot deformity. A is a forefoot deformity. And all the others, that is varus and equinus, are hindfoot deformities. Now let's understand the types. We've talked about two, that is idiopathic and syndromic. So syndromic can be of two types. They can be purely syndromic, or because of any disease that can lead on to CTEV. So at birth in some patients there will be no CTEV. But later on, because of these syndromes, there can be a secondary CTEV. So that is called as a secondary clubfoot. Syndromic is when they are born with multiple features, not just CTEV, other syndromes as well. Idiopathic is the one where there is only CTEV and there is only deformity below the knee and there are no other deformities in the body. Postural is a mild type of CTEV which can be corrected with the hand. So the patient or the mother can get the foot back to neutral with the normal manipulation. So that is a postural clubfoot, and that usually heals with simple manipulation. You don't need to do a whole technique. So it is usually healing very soon or spontaneously. Now let's understand on examination what can be seen. So first you have to detect for malformation. So whenever you're looking for CTEV, first you have to rule out whether it is idiopathic or syndromic. And how do you look for syndromic? You look for certain signs like tuft of hair in the back. That can suggest that it is a spina bifida. That can be a syndromic type. Second is if there is multiple joint contractures. I told you that in AMC, not just the foot is affected, lot of other joints are going into contracture. So if there are multiple joint contractures along with CTV, always suspect AMC. If there is a tuft of hair at the back, always suspect that spina bifida is causing a syndromic type of CTEV. Now, how to screen for a case of CTEV? If a mother is suspecting a case of CTEV in her child, how does she screen it? That can be done by doing a forceful dorsiflexion. The children's joints are very supple. So when you do a forceful dorsiflexion of the foot, you'll be able to touch the dorsal surface of the foot to the shin of the tibia. So you can see here, the dorsum of the foot is able to touch the shin of the tibia. So in such cases, you know that CTEV is not occurred. So this patient has a normal limb or a normal foot. Now coming to the classic presentation of a CTEV, they're usually bilateral. That is 60% of them are a bilateral presentation, and they have a smaller foot compared to a normal foot, and there is a deformity. These deformities are your cave deformities. C, A, V and E. C stands for cavus, A stands for adduction, V stands for inversion, and E stands for equinus. So these are the deformities that you will note. Also, there will be a small heel because the calcaneum is medially turned and calcaneum is also small. So there's a small heel. And you have deep skin creases that are seen back of the heel and medial side. So creases are seen where the deformity is there. We know that in CTV, the deformity is because of the posterior and the medial side. So even the deep skin creases are back of the heel and on the medial side. Now you have bony prominences at the lateral side of the foot, at the head of the talus and in the lateral malleolus. Because these are turned, they'll be more prominent in certain places. So lateral side of the foot, head of the talus and lateral malleolus is very prominent. And you have a convex outer side of the foot. I told you that in CTEV, the medial side of the foot or the medial column becomes smaller and the lateral side becomes larger. That's why you have a convex outer side of the foot. Now in late stages, when the patient has a deformity like that and he's walking on that deformity, the area of contact of the foot is different. So at that area, pressure will increase and that will lead to a formation of callosity. So there will be callosities seen at the lateral aspect of the foot. Because the patient is walking on the lateral aspect of the foot, there is callosities formed there, and also there will be calf muscle wasting. So these are all the long-term results where you have callosities and calf muscle wasting. Now let's talk about certain terminologies related to CTEV. We use the word supple joint when the joint is normal. So I told you that in a screening test, when a mother tries to press forcefully dorsiflex the foot such that the dorsal aspect of the foot touches the shin of the tibia, we know that it is a supple joint or a normal joint. That is, a foot can be brought to its normal position. Now, if it is a rigid type of joint, these foot deformities are not correctable. So they cannot be corrected. Resistant ones are the foot deformities that are not responding to manipulation and plaster cast. So we know that the treatment for CTEV is casting, serial casting. We'll talk about this later on. But the ones of CTEV, the variants of CTEV that do not respond to this serial casting are called as resistant type. What is neglected type? When they do not get treated from 1 year. So if treatment is not received until the first year of life, that is a neglected case of CTEV. Now, a relapse case is when treatment is taken, but this has recurred. So you have to understand this terminology exactly. A resistant one is where you have done casting, but it is not applying or it is not responding to that casting. A relapsed one is the whole course is completed and the recovery has happened. That is, the clubfoot has become normal. Now again, it has gone into a recurrence. Neglected is when treatment is not taken until 1 year. Now coming to the differences between a primary clubfoot and a secondary clubfoot. We know that primary is an idiopathic type of clubfoot. Secondary clubfoot is occurring because of some other syndromes that are coming in. So present since birth. Primary are always present since birth because they are congenital. Secondary clubfoot sometimes are present, but sometimes it is because of a syndrome which is later giving rise to CTV. So it is not possible that all secondary cases will be seen at birth. Now, side affected. So, in primary, 60% bilateral presentation. Secondary clubfoot is a unilateral presentation. Foot size is much smaller in primary, normal or small in a secondary. Now, heel size is small with a lot of fat, but here it is normal with normal amounts of fat present. Now, coming to the skin condition. Usually in primary, they have chubbiness and there are creases present in the posterior and medial side. In a secondary, it is atrophic and creases are absent. So there are no creases seen in a secondary type of clubfoot. Now, neurological examination is essentially normal because I told you in primary clubfoot, everything else is normal. Only a deformity is seen distal to the ankle or the knee joint. Now, in a case of secondary clubfoot, motor and sensory loss may be present because it is a syndromic type. Now, prognosis, primary responds well to treatment. So, good prognosis. Poor prognosis in case of syndromic because there are a lot of deformities and a lot of causes to it. So, treatment is very tedious. Now let's understand the diagnosis. So X-ray can be done to diagnose the case of CTV. In X-ray specifically, we have to get something called as the Kite's angle or the talocalcaneal angle. So you have to take, so if this is the talus and this is the calcaneum, you take the line from the long axis of the talus and you also take a line from the long axis of the calcaneum. This talocalcaneal line is called as the Kite's angle. So this angle is a Kite's angle. Normally, they are well distributed. So it is more than 35 degrees. But if the talocalcaneal angle is reduced, that is less than 35 degrees, then you should suspect a case of CTEV. So you can see in this diagram that they've taken a line from the long axis of talus and the long axis of calcaneum. In a normal foot, it is wider. But in a case of CTEV, there is a very small angle that is less than 35 degree. Hence, it is suggestive of CTEV. Another thing that you can take is the angle between talus and the first metatarsal angle. So the long axis of talus and the first metatarsal angle, they form a degree. So this angle is usually smaller, but if it increases, that is suggestive of CTEV. Now coming to another score, it is important for you to know this score because it is given by an Indian. So based on an X-ray and clinical features, Pirani, that is Shafiq Pirani, came up with a score called as the Pirani score. This Pirani score is based on two structures, the medial structure and the posterior structure. So I told you that in CTEV, the structures affected are the medial and the posterior structures. So he examined the medial structures and he examined the posterior structures, and based on these two structures, he gave a score which is very important in getting to know the prognosis of the disease, how bad the disease is, and to also gauge the response to treatment. So this Pirani score helps us know the prognosis and the response to treatment. So first, let's see the medial side. So in the medial side, he examined for the medial crease. If there is no medial crease, 0. If there is a milder medial crease, 0.5. And if there is a severe crease, that is a 0.1. Now, if there is a curved lateral border based on the lateral structure, so you can see here, this lateral border is straight. But if the lateral border is curved, that is, there is a longer lateral column, that is an exaggerated deformity. So he gave it a score of 1. And based on lateral head of talus, so I told you that the talus is rotated medially, so there is a lateral prominence of the talus. So if you feel it in the lateral column, you will feel the head of the talus. So based on how well you can feel it, he scored it into 0, 0.5 and 1. So this is the medial side. Now in the posterior side, it is based on the posterior crease, whether the posterior crease is well defined or not defined. empty heel. Now you know that the calcaneum has also gone into varus, gone into equinus, and it has gone into medial rotation. So the calcaneus, when you feel the heel, you will feel that it is empty. So if there is an empty heel that is felt, more obviously, we give it a score of 1. Also equinus. So the equinus deformity that is there, how rigid is the deformity? Can it be brought back? Is it supple or is it rigid? Based on that, he gave a score. So this whole score is called as the Pirani score. And based on what the score is, you can give a prognostic index to the disease of that patient. Now coming to the treatment. So treatment of CTEV starts right from birth. So the first thing you have to do is manipulation to correct the deformity. Initially, Kite tried a reduction maneuver. He did this maneuver thinking that the fulcrum of the disease. So the fulcrum of the disease that he believed was calcaneocuboid. So this calcaneocuboid joint, he kept the fulcrum and then he tried to reduce the deformity or get the deformity done right. But we know that CTEV fulcrum is not calcaneocuboid, but the fulcrum of CTEV is talus. That is why Kite's technique did not work, and this is commonly called as the Kite's error. This calcaneocuboid joint being the fulcrum is a Kite's error. And then came Ignacio Ponseti. So Ignacio Ponseti was a game changer. He brought in newer techniques of doing manipulation, methods of doing casting. Also, he introduced tenotomy procedure, specific methods of bracing, and also recurrence of the treatment. So everything about CTEV that we know right now is mainly because of Ponseti. So most of the treatment protocols followed is the Ponseti's technique that we follow. So let's understand what is Ponseti's treatment method. So he based his theory on the fact of retracting fibrosis. So we studied about a lot of theory of causations of CTEV, but the most commonly followed theory is not the germ theory or the mechanical theory or the ischemic theory, but now we follow the theory of retracting fibrosis. So what is that theory? It is the most accepted theory and it believes that all tendinous and ligamentous structures except the tendo-Achilles, this is very important, all tendinous and ligamentous structures except tendo-Achilles are loosely crimped and can be stretched. So I'll tell you what this means. As a child, you remember you played with clay molds and these clay molds can be converted into any shape that you wanted. So these ligaments at early stage of birth are like that clay mold. And it's like how that clay mold can be turned into whatever you want, same way these ligaments, if manipulated correctly, can be returned into a normal foot. So here, when we stretch it, so you can see here, there is a deformity and there is a contracted muscle or a contracted ligament. But when we stretch it, easily it gets stretched and the deformity is corrected by the casting. So when you try to stretch this, you will notice that the ligament gets molded, it becomes loose and the deformity is reduced. So that is the Ponseti technique. He believed that in early birth, everyone's ligaments and tendons are loosely crimped except the tendo-Achilles. So if you do a proper manipulation technique and then you cast that manipulation, you can resolve that deformity. So that is the Ponseti technique. So now, when do we start with the Ponseti technique? So when do we start the treatment? We start within first week of life. So we wait for 1 week until the foot becomes malleable to manipulation or the skin condition becomes better. And after that, we start it. So why do we start early? This is to take advantage of the favorable fibroelastic properties of the connective tissue. I told you that in initial stage of birth, that foot is like a clay mold. It can be shaped to correct the deformity. So it is better to start early so that you can take advantage of this favorable fibroelastic property. And here the fulcrum is important. So I told you in Kite's technique, he took the fulcrum as calcaneocuboid. But the fulcrum of any disease in the CTEV starts from the talus. So Ponseti's technique, the fulcrum is taken at the talus. That is, any deformity manipulation that is done, one finger is kept at the talus and then it is manipulated. Now let's understand the deformity correction. So the deformity first corrected is cavus and then adduction and then equinus is corrected. So this is the order of correction. So first, how do we correct the cavus? It is corrected by elevating the first tray or the first thumb and bringing it in alignment with the hind foot. So you can see here with one finger on the talus, that is the fulcrum. So one finger is kept at the talus and with the other hand, there is elevation of the first tray. So the first great toe is elevated and it is brought in line with the hind foot. So when you're doing this, that cavus deformity with the lift gets corrected. So the cavus is reduced. After the cavus is reduced, then you correct the adduction. Correction of adduction is by abducting the entire foot under the talus with foot in slight supination. So abduction and slight supination. So you do the opposite. The foot is in adduction, you get it into abduction and slight supination. So by doing this, you're correcting the adduction force. The next one is correction of ankle equinus. So I told you that Ponseti said that any muscle or any ligament can be stretched in early childhood except for the tendo Achilles. Now we know that tendo Achilles is the reason that there is an equinus deformity. So equinus cannot be corrected by a Ponseti technique. You have to do something different, and that something different is a tenotomy. So the correction of ankle equinus is by doing a percutaneous tenotomy. Now let's understand what is done after the manipulation. So once you've done the manipulation, you corrected the cavus, you corrected the adduction, you corrected the equinus. After that, you put a cast. And this cast is an above knee cast that is applied. And in this, the knee is kept at 90-degree flexion. And this cast is applied every 7 days. So there is a change of cast that is done every 7 days. And it is usually corrected within 6 weeks. So the duration of treatment in most cases is 6 weeks. So you can see here at stage 1, this was a deformity and a cast was put after elevation of great toe, and then serial casting was done all the way till 6 weeks, and then you have a plantigrade foot. From a deformed foot with cavus, equinus and varus deformities, you have a plantigrade foot in which the patient is able to walk. So now you must be wondering that we've corrected the cavus. We've also corrected the adduction. With percutaneous tenotomy, we also talked about correction of equinus. But what about the varus? We've not talked about the varus yet. So we need to understand that varus gets corrected automatically. So when you correct the cavus and the adduction, even the varus gets corrected. This is because of a phenomena called as kinematic coupling. So that means that any correction that you do in the forefoot will also get transmitted to the hind foot. So imagine, you know that in CTEV, you have deformity of the calcaneus, that is adduction, inversion and flexion. So when you hold the talus as a fulcrum and you do your Ponseti technique, that is supination and abduction of the forefoot, this correction of the forefoot will also travel to the hind foot. So there will be abduction, eversion and extension of the calcaneus, because of which the heel varus will get corrected. So the heel varus gets corrected by the abduction of the forefoot. And how does that occur? That is by kinematic coupling, where a correction in the forefoot will also cause a correction in the hind foot. Now let's talk about equinus correction. So after we've done with the Ponseti technique the correction of cavus, adduction and inversion and varus, then we move on to equinus correction. We know that tendo Achilles cannot be corrected by a Ponseti technique, and we need to do an additional surgical procedure called as percutaneous tenotomy. So in this, using a needle or using a scalpel, we make a cut. Percutaneously, we make a cut on the tendo Achilles, and this cut is called as the Achilles percutaneous tenotomy, where the final position that we'll get is a dorsiflexion of 10 to 15 degree and an abduction of 70 degrees. So after we do the correction and then we do a percutaneous correction and equinus correction, we get a dorsiflexion of 10 to 15 degrees and an abduction of 70 degrees. Now that we've got that reduction, it is very important to maintain it. It shouldn't go into another deformity. So how do we maintain a case of CTEV? So once the manipulation phase is over, we then move on to the bracing phase, where we keep the foot under braces. So what are the braces used? You've commonly studied about a Dennis Brown shoe. So commonly Dennis Brown shoes are used, but nowadays we use something called as a Stenbeck abduction brace. The concept of both these braces are the same, but they just have different names. So this is a Dennis and this is a Stenbeck abduction brace. Now let's see what is done in bracing. So when you brace a foot, the affected side is kept at an external rotation of 60 to 70 degrees. So the affected foot is kept at an external rotation of 60 to 70 degree, and the normal foot, the unaffected foot, is kept at an external rotation of 30 to 40 degrees. Also, a 15-degree dorsiflexion bend is given to that bar so that the foot is in 15 degrees dorsiflexion. Also, the width or the abduction that is there should be 1 inch wider than the shoulder width. So if your shoulder width is this much, you have to make a 1 inch wider bar. So the bar is made more than the shoulder width. Also, you have to have a low heel counter. So these are all the features of the brace that is used. That is your Dennis Brown brace or your Stenbeck abduction brace. In these braces, the features are that affected side, external rotation kept at 60 to 70 degree, 15 degrees of dorsiflexion bend is there, and abduction is because of a 1 inch wider, more than shoulder width bar that is put up, and there is a low heel counter in the shoes. So because of all this, correction occurs. Now, for how long should the bracing be kept? So in the initial first 3 months after doing Ponseti, 23 hours a day, only for 1 hour you can remove that brace. And other than that, rest 23 hours the brace should be kept on. Now as time goes on, 2 to 4 years, only night it is used. So after, when the child is second year or till the 4th year, you can use this brace in the night, and while walking he can use a Ctev shoe. So we'll talk about a Ctev shoe later. So that will be used during the day, and this brace will be used in the night. Now this is a Ctev shoe. So when the child becomes 2nd to 4th year, or when the patient starts to walk, in such patients in the day you can use a Ctev shoe. And these shoes are different from your normal shoe because they have a straight inner border. So we know that the lateral column is lengthened and the medial column is shortened in case of Ctev. So using this shoe, we are trying to correct that deformity as much as possible. So a straight inner border is given and an outer raise is given, and there is no heel put because we know that the foot is already in equinus and varus. That is why there is no heel put. So the features of a Ctev shoe is a straight inner border, an outer raise, and also no heel. So we've talked about Ponseti's principle and the theory of retracting fibrosis, that in any newborn, the soft tissue is like a clay mold which can be easily malleable. That is if the child presents to us immediately after birth. But what if the child presents to us late? And Ponseti technique cannot be done in such children because their soft tissue is not malleable and they've got a soft tissue contracture that is irreversible. So in such cases, you have to do a soft tissue procedure. So in children less than 2 to 3 years, we do a soft tissue procedure. That is, if there is only an equinus deformity that is remaining and the other deformities have been corrected, then you do a tendo-Achilles lengthening or a release. Now the same way, if the tibialis posterior is deformed and that is leading to a Ctev, in such cases you can do a tendon transfer. You can replace tibialis posterior with a tibialis anterior tendon. Now if all the posterior medial structures, so I told you in Ctev, all the posterior medial structures can get affected or contracted. So in such a case, you have to do a posterior medial soft tissue release, that is a PMSTR, also called as the Turcos operation. Now in some cases where all the soft tissue have gone into contracture and damage, you have to do a complete soft tissue release. So these are all the soft tissue procedures that are followed. So let's understand Turcos operation. So a Turcos operation is a posterior medial soft tissue release. So it involves the posterior structures, medial structures, and also the plantar structure. So the posterior structures are the tendo-Achilles. This tendo-Achilles is lengthened or a Z-plasty is done. So if you have a tendo-Achilles, that tendo-Achilles is released in a Z fashion and that way it is lengthened. Now a release of the posterior capsule is done. So capsule of the ankle and the subtalar joint are released. Also, posterior talofibular and calcaneofibular ligaments are released. So these are all the posterior structures that are released. Medially, you have your three tendons, that is Tom, Dick and Harry. So tibialis posterior, flexor digitorum longus and flexor hallucis longus. So all these three tendons are lengthened because they've gone into contracture. They are lengthened. Also, you have to release these three ligaments. We've talked about the deltoid ligament, the spring ligament and the talonavicular ligament. These are also contracted, so you have to release these three ligaments. And additionally, three more ligaments are released in severe cases, that is talocalcaneal and capsule of navicular-cuneiform and cuneiform first metatarsal joint. So simple way of remembering the medial structures is that three tendons are lengthened, three ligaments are released, and three more structures are released in severe cases. So 3, 3, 3. Now coming to plantar structures, your plantar fascia is responsible for the cavus movement. So plantar fascia is released. Also short flexors of the toe, that is flexor digitorum brevis is released. So this is the posterior medial soft tissue release where structures posteriorly, medially and also plantarly are reduced. So you can see here, these are the medial structures, these are the posterior structures. So you're doing a posterior and medial soft tissue release. That is your Turcos operation. Now let's understand limited soft tissue releases. So in some cases, most of the deformities are corrected. Only one residual deformity remains. So in conditions where only equinus remains, we know that equinus is caused by tendo-Achilles. That is a posterior structure. So you have to do a posterior release. Now, if there is an adduction deformity, you know this adduction deformity is caused by medial structure. So you have to do a medial release. And if there is a cavus, we know that the cavus is caused by contracture of the plantar fascia. So you have to do a plantar release in cavus deformity. So now patients that present to us after 3 years, they not only have a soft tissue contracture, they also have bony changes. So in patients above 3 years, we have to correct not just the soft tissue, even the bone. That is why in these patients, they require bony procedures plus soft tissue release. So what bony procedures are done? That is your Dwyer's osteotomy, Dillwyn-Evans procedure, wedge tarsectomy, and triple arthrodesis. So I'll explain all this to you. First, let's draw a cavus or a CTEV foot. Okay, so this is a foot in a CTEV. This is the medial side. This is your talus. This is the calcaneum. And this is the cuboid. And this is the naviculi. So this is the medial side. So you have a shorter medial column. Also, you have a longer lateral column. So what surgeries can you do? So if you do a soft tissue release, so imagine you do a PMSTR, that is a Turcos operation. By doing this, you're lengthening the medial column. But if that is not enough, then you have to shorten the lateral column, and that is done by these bony procedures. So in Dwyer's osteotomy, you make an osteotomy in the calcaneum, and with this osteotomy, you're trying to reduce that lateral column. Also in Dillwyn-Evans procedure, you're taking a cut out of the cuboid and you're taking a cut out of the calcaneum, and then you're doing a calcaneo-cuboid fusion. So you're cutting a part of the calcaneum, but cutting a part of the cuboid, and then you're doing a fusion of the calcaneum and cuboid. That is reducing the lateral column. Again, in wedge tarsectomy, you're taking a small wedge out. You're taking this much wedge of bone out, and by taking that wedge of bone out, you're reducing the lateral column and you're increasing the medial column. So you're getting some kind of equilibrium. Even in triple arthrodesis, you do a fusion of 3 joints that is leading to reduction of a lateral column. So this is the basis of doing every bony procedure. Let's talk about each bony procedure in detail. So first is the Dwyer's osteotomy. In this, we correct the varus of the heel. So when there is a varus of the heel, you take an osteotomy cut out and you put a bone graft, and with that bone graft, you're correcting the varus. And this is done minimum in a 3-year-old child. So the child has to be at least 3 years old for doing a Dwyer's osteotomy. Second is a Dillon-Evans procedure. So in Dillon-Evans procedure, you're taking a part of the calcaneum out, a part of the cuboid out, and then you're doing a calcaneo-cuboid fusion. By doing this, you're reducing that lengthened lateral column, and this is done along with the turquoise operation. So turquoise operation is PMSTR, where you're increasing the medial column. So this is done in a neglected or a recurrent clubfoot in children at the age of 4 to 8 years. So I hope you understand Dillon-Evans osteotomy. Next is a wedge resection. So a wedge tarsectomy, where you take a wedge of these tarsal bones. So you can see here, a wedge cut is taken in such a way that it is reducing the lateral column. So this is done by removing a wedge of bone from the mid-tarsal area. So you know that it is a wedge where tarsal bones are cut. So removing a wedge of bone from the mid-tarsal area, and the wedge is cut with its base on the dorsolateral side, because you want the dorsolateral side to reduce more. So you make that cut with the base being at the dorsolateral side, and the foot is then brought to plantigrade position. So from it being inwards, it is now brought to a plantigrade position. And this is done also in neglected clubfoot in children of 8 to 11 years. So comparatively older children, wedge tarsectomy is done. So now let's talk about triple arthrodesis. So triple arthrodesis is fusion of 3 joints. The joints are the subtalar joint. So you can see here, this is the subtalar joint, the calcaneo-cuboid joint here, and the talonavicular joint. So these 3 joints are fused, and this is done at the age of 12 years, because before 12 years, the bones are cartilaginous and difficult to fuse. So you cannot achieve triple arthrodesis in children less than 12 years. Only when it is 12 years, the bones become fit for fusion. That is when a triple arthrodesis is done, and the 3 joints are the subtalar joint, the calcaneo-cuboid joint, and the talonavicular joint. Now let's understand the other technique, that is the Ilizaros technique. So Ilizaros technique is gradual stretching using an external fixator, commonly done in neglected clubfoot, and nowadays we moved on to other fixation techniques, that is the JESS, which is a Joshi's external stabilization system, which is introduced by an Indian. So a JESS fixation is also used, or an Ilizaro fixation is done, mostly in neglected clubfoot, where gradual stretching to get the deformity back to the plantigrade foot. Now surgeries are done in which cases? So I told you when they present late, also in cases where there is a resistant CTV, where it is not responding to treatment of Ponseti, or a recurrent CTV, where after doing a manipulation, it has become normal, but then again it has recurred into a deformity. So a resistant CTV, a recurrent CTV, and also a neglected CTV. If the patient comes to us after 1 year, in such cases surgery has to be done because Ponseti is not effective. So now let's understand the diagnostic algorithm of a case of CTV. The first thing we have to do is we have to differentiate a syndromic CTV and an idiopathic CTV. So in a syndromic CTV, there will be a neuromuscular cause. So first you have to examine and rule out this neuromuscular cause, and when you understood that there is no neuromuscular cause, then you can group it as an idiopathic clubfoot, and the treatment for this idiopathic clubfoot depends on the presentation. If it is a fresh case or an old and neglected case. So if it is a fresh case of CTEV, in such a condition, first thing you do is a Ponseti method of serial casting for 2 to 3 weeks. So you have to do this manipulation technique that was introduced by Ponseti, where you correct the cavus, you correct the adduction, you correct the inversion, also the equinus should be corrected later, and that correction is done by percutaneous tenotomy of the tendo-Achilles. So once you do Ponseti serial casting, then you move on to percutaneous tenotomy of the tendo-Achilles. After that, you look for correction. If correction is achieved, then you maintain that correction in first a Dennis Brown splint or a brace, and following that you should use a CTEV shoe. So first you use a brace, and when the patient starts to walk, you reduce the brace only for the night, and in the day you use CTEV shoe. And if correction is achieved and the progress goes well, then CTV gets corrected. But if not all corrections happen and there are some corrections that is seen till 4 to 6 months, then these corrections need to have a soft tissue release. So if there is an equinus deformity that is still left, you have to do a posterior release. If all deformities are left, you have to do a turquoise, that is a posteromedial soft tissue release. Also, if only heel varus is there, you know that the heel varus is caused, you can correct it using a Dwyer's osteotomy. So you make a wedge osteotomy of the calcaneum and you do Dwyer's osteotomy. This is in cases of a fresh CTV. Now let's talk about case where it is neglected or an old case of CTV. In such a condition, if it is less than 3 years, you do a soft tissue release, that is a complete release or a turquoise posteromedial soft tissue release. If it is 4 to 8 years, you can do an Evans operation. If it is 8 to 11 years, you do a wedge tarsectomy. If it is more than 12 years, you do a triple arthrodesis. And if the technique is already bad or if the correction is already bad, then you have to do an Ilizaro technique. So with an Ilizaro technique, you can correct a neglected case with gross deformities. So now let's summarize CTEV. So first let's know the etiology and theory. The etiology is either an idiopathic type or it can be an acquired or a syndromic type. In an idiopathic type, there are no deformities below the knee level. It is only in the foot and in the ankle region. And the main causation or the theory of causation are either an increased mechanical pressure in the intrauterine life, or also if there is an increased ischemia seen in the intrauterine life, or there is a germ cell defect. Now, for cases of syndromic ones, there is either paralysis of muscle, that is one muscle is more powerful than the other, that is leading to increased or overriding of that muscle. And secondly, in arthrogryposis multiplexa, you see that these muscles are defective. So they go into fibrosis, causing multiple contractures. So that is the etiology and theory. Now types, two types, idiopathic, also syndromic. Also, they can be called as postural type and secondary CTEV. Now coming to the pathoanatomy, we know that every structure, the bone, the ligaments, muscles, all are damaged, and the main ligaments and muscles that are damaged are in the posterior and in the medial structure. So it is the tendo Achilles, also the Tom, Dick and Harry, that is your tibialis posterior, your digitorum muscles and your longus muscle. So all of these are damaged. Along with that, the deltoid ligament, spring ligament, capsular ligaments, all of them are contracted, leading to a posteromedial defect, causing a cavus deformity. Now coming to the deformities, we know that it is C, A, V and E. C is cavus, A is adductus, V is inversion, and E is equinus. So all these deformities are seen, and cavus deformity is seen in the midfoot. Adduction is seen in the forefoot. And these two deformities, that is inversion, equinus, is seen in the hindfoot. Now coming to the presentation, it is usually a bilateral presentation. There is a smaller foot which is always having an empty heel. There is an inward movement and there is crease present in the medial and in the posterior structure. Later on, we see there is presence of callosities and also calf atrophy is seen. So all these changes are seen in a CTEV foot. So that is the presentation. In diagnosis, you can get x-rays done. In x-rays, what you see is a Kite's angle. Kite's angle is the angle between the long axis of talus and long axis of calcaneum. If it is less than 35 degree, that is suggestive of CTEV. Also, another one is the angle between the first metatarsal axis and the talus. If it is increased, that also is a condition of CTEV. Now, Pirani score, he considers the criteria that are there in the medial structures and in the posterior structure. So, three criteria from the medial structure and the posterior structure, based on which he can predict the prognosis and the treatment response that is there. So, that is the Pirani score. The Ponseti technique was introduced by Ignacio Ponseti, and that is the treatment of choice for case of CTEV that is presenting acutely or a fresh case. In children who are just born, 1 week later, you can start Ponseti technique. And how is it done? You keep the fulcrum at the talus and then you raise the first toe in such a way that the cavus is first corrected. And then you do an adduction is corrected by an abduction, and a supination force. That way you've corrected the adduction deformity as well. And the third thing, that is your equinus, is corrected by doing a tenotomy, a percutaneous tenotomy. Now, how is a varus getting corrected or an inversion getting corrected? This is getting corrected by a kinematic coupling. When you're correcting the forefoot, even the hind foot gets corrected. That is, adduction of the hind forefoot is corrected by abduction. That also corrects the varus. So that is kinematic coupling, and that is a Ponseti technique. And after doing that, you do serial casting all the way up till 6 weeks. You do serial casting every week. And after that, when the foot becomes normal, you do a percutaneous tenotomy, you get dorsiflexion, you get abduction movement, and later you use something called as a Steinbeck's abduction brace or a Dennis Brown brace. And you keep that foot in that brace 23 hours a day for around 2 years. Now from second year to fourth year, the bracing is done only in the night. And in the day, when the child is walking, you give him a CTEV shoe. So after doing this, if the correction is done, then you know that it won't recur back. But if there are still soft tissue damage that is there, or if the child is presenting to you after 2 years, in such a case, you have to do soft tissue release. If it is isolated, if there is only equinus deformity, then you can do a posterior release. If there is only cavus deformity, you can do a plantar release. So if there is a complete deformity, then you do a posterior medial soft tissue release, also called as a turquoise operation. Or you can do a complete release if there is a gross deformity. But if the deformity has occurred more and even the bone is affected, in such cases you have to do a bony procedure. The bony procedures done are Dwyer's osteotomy, Dillwyn Evans procedure, wedge tarsectomy, you can do triple arthrodesis. Also in gross deformities, you can use a Ilizaro fixation or a Jess fixation. So these are all the bracing techniques and the shoes. So let's summarize what are the surgeries done with this diagram. So I've told you that the lateral side and the medial side have a gross deformity. So we know that the medial side is short and the lateral side is long. So soft tissue procedure, that is PMSTR, is done to increase the medial side. Bony procedures are done in the lateral side. One, you can do a Dwyer's osteotomy where you make an osteotomy in the calcaneum. Another, you can remove a part of the cuboid and a part of the calcaneum and do a calcaneo-cuboid fusion. That is your Dillwyn Evans procedure. Another is you can make an osteotomy or you can make a wedge and remove that tarsal segment. That tarsal wedge we can remove, that is called as wedge tarsectomy. Also, you can do fusion of 3 joints, that is a triple arthrodesis. See, these are all the bony procedures that are followed. So now we've comprehensively studied about every aspect of CTEV. So that's all for this session.